panel discussion is going to be a conversation to explore how together can we focus on prevention of future pandemics, but at the same time, how do we kind of build our health systems, strengthen them in a way that they are resilient to any kind of disease outbreaks in the future. So without much ado, I will hand the stage over to Dr. RK, who not only is a Precision Health partner, but is also going to be the moderator for this discussion. Dr. RK.
Thank you, Spriha. So what I'll do is I'll invite the panelists over first. Could I invite Ben Pine? He's the principal at the Skoll Foundation. Ben, many thanks to you. I don't think this program would have come this far without the support of Skoll Foundation. Dr. Varsha Sridhar, my friend, philosopher, guide in life. Varsha, there is no doubt, I would not have come here. Okay. Shama, Senior Director at Swasti. Shama, this is the second panel we are doing together in the last 3 months. Yeah. Shri Abhay Pandey, Additional Commissioner, Lucknow Nagar Nigam. Sir, it's really important to have government representation, so we're very thankful to have you here. And Teja Malladi. He's from MapSolve AI. Thank you, Teja. So I'll start by saying, so I'm a physician. I'm a family medicine physician. I'm also an infectious disease and public health physician. I have to say that this journey has been one of the most enriching journeys personally for me, Precision Health. And it's transformed truly. I mean, I recently learned, a few months back, I learned of, I learned what is an epistemic transformation, where your philosophy transforms. And I think Precision Health as a group has done that for me. In spurts, in conflicts, in disagreements, and in a lot of outstanding work together. As a clinician, I'll start this conversation by saying, I mean, hats off to Angela. When COVID happened, and I'm not just saying this, because I was one of the people who would have questioned, Angela, really seriously. So when COVID started, COVID for me personally gave a great sense of deja vu, because when I was a Master's of Public Health student at the University of Pittsburgh, my master's thesis actually was on predicting the next influenza pandemic. In 2005, 2006, we all used to think about H5N1, bird flu, and we thought that'll become the next pandemic. A pandemic did happen in 2009. It was H1N1. But when, and I worked on this with a CDC-funded grant for 3 years. And then, you know, conversations around influenza settled down, because that's one of the things I hope we discuss. And I'll showcase some of the data Precision Health has generated in influenza in the last few months. So when this idea came, and Angela was the first to say, I was busy at that time trying to set up COVID care centers. I'm a family medicine doctor, and my thought was, we need to have systems or interventions which prevent people from unnecessarily going into hospitals. And if we can do that at home, and if we can do that at a COVID care center where people are not very sick, but you can prevent them, then that's a meaningful intervention. Angela came up and said, we should be testing sewage. It was a new idea for me with COVID. And honestly, it wasn't even established very clearly as to whether there was viral shedding in the stool at that time. So thanks, Angela. And then I take pride there's a sewer which flows very close to my house. And Varsha and team of, you know, fearless detectives went and scooped some water. And there was this new technology at that time, which is called TrueNat. It's in India's indigenous, you know, PCR platform, a portable platform. And Varsha's team had set up a TrueNat COVID testing center at a primary health center just then. And she took this and tested it on that device, and that's how we found COVID. So what I want to do over the next half an hour or so is actually engage in conversations around a few questions. I'll invite, and we'll play it by the ear. It'll be interactive. I don't have a script for this. I'll start by asking Ben. Ben, tell us a little bit of your thinking. You know, so COVID strikes. And I'm sure as a philanthropic organization, you have several decisions to take. Where do you invest your resources? What ideas do you invest your resources in? And what should that innovation achieve in the short term and in the long term? How did you and the Skoll Foundation think through precision health, and why did you feel precision health would be something that would accomplish these goals?
Is it on? Hey. Thank you. And you all heard some of this before, so I'll be brief because I want to hear from my other, my fellow panelists. But I think for Skoll, you know, if we think back to the early days of 2020 and the pandemic, I mean, I know that, you know, here there was a severe lockdown. In many countries, there are severe lockdowns. And there was a lot of, there was a lot of shared thinking and kind of dissemination of knowledge and tactics and other things like that across the world, right? Like scientists were advising each other, politicians were advising each other, people were taking decisions. But I think that one of the things we saw in our early COVID response was that people were not considering deeply the local context in the kind of things that they were advising and the kind of things that they were, I mean, honestly, shaming some other countries for. Like, I think Ethiopia is a good example. We have a lot of work in Ethiopia. And Ethiopia is a major transportation hub for East Africa and the whole continent, the whole world. And Ethiopian Airlines was still running at full speed. They were still running flights to China. They were still operating their economy. Of course, they had some public health restrictions, but on the whole, they were looked at, especially by the West, as somebody that was not doing the proper COVID protocol. But for the context of Ethiopia and the context of their economy and their people, the age of their population, in hindsight, it was the right choice. And I think we looked at a lot of things early on in the pandemic that felt more like imposing particular solutions or particular decisions upon the world. And I think a lot of that has to do with the power structures and the funding flows and where power and finance sits. And a lot of it is self-interest, right? And I think that, so I think we saw that. I think we saw this self-interest. There's nothing wrong with self-interest. But if you're feigning self-interest to protect the U.S. and Europe from existing pathogens without considering what the needs of the local context are, then I think you're in trouble. And so I think what we were really excited about with Precision Health was a collective of people who identified a solution that worked for Bangalore and then can work for other cities. And I think that was really the impetus of us trying something like this and taking a risk, was that it actually looked very different from a lot of the things that were being championed around COVID solutions, around pandemic prevention, around pandemic preparedness. And I think the foundation has a value that says, trust those who are closest to lead the challenge, that's right. And I think that's what we seek to do. And I think that's what our partners also seek to do. I think many of us in here are privileged. We're not experiencing the same things that many of the communities who are on Open Dreamers are experiencing, but it's about the ethos of equity and of actually trying to design things locally and proximately that we're really excited about.
Thank you so much, Ben. Ben, I'm going to come back to you with some more future funding directions questions. But Pooja, if I could ask you, if someone could give a mic. So crypto relief came in, not to put you on the spot. It's just that you're here and it's so valuable to have this kind of a dialogue. So Pooja, by the time crypto relief, for example, started becoming interested in a platform like Precision Health, a lot of learning had already happened. A lot of the science of COVID and wastewater had begun to emerge and take shape. How would you say your own decision-making process as an agency or organization and you personally would have differed from some of the early investors, if I could ask that?
Sure. Can you hear me? Yeah. So, like you said, when we started thinking, so I'm a molecular biologist by training, right? And the science, the first steps, the work done by, sorry, am I audible just like, no? Okay. So a lot of work was done when I personally got involved. And being a molecular biologist, when Angela said scientist in the field, for me, the science made sense and the impact it was having in public health. And what we wanted to do was to encourage that. We felt that this is the time we can promote some of the work that was being done, support it, and actually bring different sectors. So that's how the idea for Indian Alliance for Public Health Preparedness came about. We wanted to show the good work being done, bring others from different sectors, interact, share ideas, and make this more approachable and accessible, right? So that's where our thoughts as an agency, as me personally, it came into being.
Oh, great. Thank you, Pooja. Towards the end of the panel discussion, I'll come back actually again to you, Ramnath, and Ben, about some of the ways forward in terms of future funding, in terms of the shape it should take. But I'll come to Shama, you. So, Shama, as a seasoned public health professional and someone who excels at catalyst, why did you think, and I know what Swasti stands for, Swasti thinks about the hardest to reach and the last person. Why did you think wastewater surveillance or wastewater, a platform like Precision Health, would actually address health disparities or equity challenges?
I think while Angela was speaking earlier today, she actually made mention of this, right? I think when the pandemic started, we realized very quickly that while in normal circumstances, the health systems are not delivering for everyone, right? We know that in peacetime, so we say, right? But during the pandemic, those cracks actually opened up. And we all saw what was happening to those who did not have access, the typically marginalized, right? And while there was an effort to say, can we get basic services in, health services, etc., I don't think we were still talking about prevention. Like you said, everybody was like, oh, let's set up the centers, let's look at how healthcare services can be delivered. If they're sick, what can we do? But how do we look at and say, for all our populations, what can we do, right? So that we're actually able to prevent this, target this, give them the information that they needed. And that is not just about saying, oh, here's a test when you have the symptoms, because we knew everybody was not going to be able to get the test or not understand about the test, etc., right? So I think for us, it was about equity is not just about saying we're able to reach everyone with services. How can we do this differently fundamentally, right? Which means that we even look at something like testing or getting the information out in advance as an equity measure, right? So, I think the biggest thing for me, at least, even personally learning, is to say that individually we could have tested, and it became about whether we had access to those people or those people were able to come and say. But what if we were able to look at populations, entire wards, entire parts of the city, and saying whether we get testing or not, we know something is going to happen there, and we can start to prevent it in advance or prepare for what can happen there, not afterwards, but before, right? And truly look at public health from a prevention lens and from an equity lens, which is what I think we were able to do with Precision Health.
Wonderful, Shama. Actually, I used to think about this. Like, how do we translate the insights we are getting? For example, the wastewater RNA level. What do we do? How do we work with Dr. Bhaskar? Dr. Bhaskar was the chief of the COVID war room during this whole period. What do we communicate with them? And actually, I will say that during COVID, it was challenging because things were so much in flux and such rapid flux. But I recently realized the value of this during influenza. So in India, for example, India actually has multiple epidemiologies of influenza. In certain parts of the country, you have a more temperate epidemiology, similar to the US. In the winter, you get it. In other places, you find a post-monsoon peak. And in some other places, the pattern is different. The best time to vaccinate a population is about 2 months before the peak. One of the things we realized was as Varsha's work grew, and for the first time as a clinician and someone interested in infectious disease microbiology, we have data in our lab where we have data from clinical samples. We know the utilization peaks. Because what happens is, there's a buzz. People start getting respiratory illness. People start hearing about respiratory illness. People start ordering tests. And there's increased utilization. But we saw last year that there was a bimodal peak. There were 2 peaks with influenza. The first was post-monsoon, largely predominated by H1N1, influenza A, H1N1, with some B. And then there was a second peak in February, March of this year, where in the first peak in our lab, for example, in clinical samples, we saw a 40% test positivity rate. In the second peak, we saw the same utilization, but we saw 12% test positivity rate, most of it being H3N2, which actually throws up such useful, valuable questions and answers for clinicians. Like, for example, me, now the monsoon is about to start. I know this is a great time based on last year's epidemic, and we have correlation between what did we see in clinical samples and what did we see in wastewater. And I was reading a paper from Manipal, which has, so one of the concerns is for resistance in the influenza virus to oseltamivir or Tamiflu, which often gets abused because anyone you hear with cold, people start prescribing, and there is increased resistance. So these are signals you can use, and if in wastewater, which is cheap, doing surveillance in wastewater is significantly cheaper. If I get the first signal, I think as a clinician, and I'm the president of the Academy of Family Physicians of India and Karnataka, I can actually tell all my colleagues, guys, we are beginning to see the peak. The peak is not here, but the peak will be here a month from now, 2 months from now. Start vaccinating everyone, especially those at highest risk. Someone who is older than 65, someone who's a diabetic, someone who has some other risk factor for increased risk of hospitalization or death from. And I saw the real potential of precision health and immediate translation of this into practice networks, governments, etc. So I am now fully convinced, that this can play that role in equity. I'll come back to you, Shama, because I want you to answer, how can we translate the equity agenda better as we move forward? I'll come to you, Teja, next. I'm not ignoring either Shri Pandey or Dr. Varsha Sridhar, but educate us. Tell us a little bit about what does AI, artificial intelligence, MapSolve, what is the role that you see playing in precision health and initiatives of this nature to solve the problem of the health equity agenda?
Thank you. I think just to kind of also clarify a few things, I think AI is a little bit far ahead. I think we are trying to reach there. It's, I think what we are trying to do is also, I think, to be able to slowly get there. So I kind of adding to the other points that were mentioned earlier, everybody poops, but all the poop is not going in the same direction and through the same channels. We don't, so the last census was, let's say, in 2011, and maybe that data was collected in 2009. So we don't know where people are living. We don't know where, let's say, to kind of add this, where people are pooping, we don't know. And how many people have toilets, how many people don't have toilets. All of these are the questions. And if it is a decision making, if it is, let's say, I think to be able to take these decisions and also in a quick manner, we need to also know where to act and how to act also. So there are, I think, advances in terms of, let's say, for example, methods in terms of, okay, what do we do in terms of, there is, let's say, patterns of, if you have large data sets, you can then start to analyze patterns and all of that. But in, let's say, in Indian context, let's say Bangalore, let's say, have a good system, but what about all the other cities in India, all the other places? Because we don't have systems to be able to generate that kind of a data at scale. And that's what we try to address through the work that we do. We primarily use satellite data and then combine with other data. Satellite data also has become much widely available and easily available for a lot more people. In using that, we would be able to not then restrict ourselves, and physical resources don't have to be there. All you will be able to do is you will be able to access this, and there is also a lot of open data thing that is being made available through, let's say, governments, public institutions and all of that. So that kind of a data is what we're trying to use. And there are also, of course, I mean, to go into the technical things, what is freely available, what is, let's say, paid, and all of that is again another round of things. So we try to do things which then be able to tell us, let's say in the context of the work that we did with Swasthi and the Precision Health platform is, they were collecting samples, but we wanted to also then collaborate with them to see where this water is coming from and how many people are living in this. And the next step is to be able to see what kind of population are living in what kind of conditions, for example. To be able to say that, say, for example, if we kind of say, and to be able to say, okay, if there is going to be a certain kind of outbreak, where it is likely to be, and in other senses, where the vulnerable population are, who are likely to get more exposed. And that's the kind of a thing that we started to work with. So, and to be able to, I think to take also a step back, for us to be able to, whether it is pandemic or any other kind of disasters, for example, to be able to react quickly, we need to also to be prepared, and that's where I think we kind of think these kinds of data sets, these kinds of analysis would be helpful, because these also can be generated on a regular basis. There is no lag in terms of, let's say, to understand where this is happening, how this is happening, and then you can combine with a lot more other indicators to be able to say, oh, why is that happening? Is there a cause to it? And what can be then done to be able to do things about it? This is one kind of, let's say, health, and there are also, let's say, for example, health indicators in terms of heat-related stress, access to, let's say, parks, for example, other kind of mental health issues, all of that in kind of, you kind of start to kind of then correlate. But the main thing is where people are, how they are living, and what kind of issues that they do deal with on a day-to-day basis. If you're able to do that, then we will be able to also then collaborate a little bit more to be able to do better response.
Thank you, Teja. Shri Abhay Pandey. Sir, many times for those outside government, it can be very challenging to work with government at a few levels. Number one, the government is in many ways a universe in itself. It's got its own structure, and which is not necessarily very easy to understand. Could you share? I mean, I'm so excited that you are here. Could you share, as an administrator, and as an administrator of very complex systems at huge scale, anywhere in India, how do you, as a leader within government, view conversations like this, and how do you see the translational or partnership processes forward?
Thank you. First of all, I would like to clarify the role of the government in such things. In one line, if I say, government has no business to do business. Government's role is depending upon the level of development in the country. If you see the intervention of government in a underdeveloped country, in a developing country, in a developed country, then you see that the role of the government is different. We have a variety of stakeholders in any society. Government is one of the stakeholders. We have private sector, we have academicians, we have media, we have so many factors to it. So if you see, the role of the government is to, for any sector, the role of the government is to formulate policies, make decisions, and to facilitate the different stakeholders in doing their business, and to set up some kind of regulatory mechanism to control if there is any deviation which is taking place against the interest of the society. For example, Competition Commission of India, SEBI, we have medical boards. So the role of the government is to regulate the things, facilitate the environment, and not to do the business, which is for others to do. Why we are here in the healthcare sector, be it the primary healthcare, secondary, tertiary healthcare system, we are here because we are moving from underdeveloped countries, now a developing country, and we are moving towards a developed country. So due to this transitional stage, there is a lot of people who are marginalized, vulnerable section of the society, tribal areas, rural areas, where they don't have access to healthcare system. So in these particular cases, we have come up to fill the gap, and the government is providing various services. As you see, in the many sector, government is withdrawing himself, and he is promoting the participation of other sectors, and other sectors are taking over it. For example, in this, what we are doing with Precision Health and Integral University, in the Lucknow Municipal Corporation, we came up with the project. They are taking the wastewater samples from different drains, STPs, and they are measuring the viral load of the COVID virus. And during the pandemic, after the second wave, they started sharing the data of the viral load from the different sectors. So from the figures, the government or the municipal corporation is the third tier of governance in the system. The Lucknow Municipal Corporation is, from the data, is able to identify the pockets from where there is a higher viral load. There are chances of possible outbreaks from those areas. So we start coming in the picture. We have our Nigrani Samitis at the ward levels where we see community participation, and we tell them that this particular area, there is some kind of possible outbreak. So we direct them about the social and behavioral changes, what preventive measures you need to take place. We make containment zones in those particular areas so that we can contain the movement of people from such areas, and we can do targeted sampling, we can do targeted delivery of medicines, we can identify the people from where the outbreaks can reach in the other sectors of the city. For example, if you see China, if the COVID virus could have been prevented in the Wuhan itself, then it would not have a spread to the other parts of the country. So, but if you see in the Indian context, it is started from somewhere in Kerala, from Mumbai, and then it is spread to all across the India. So, if you look at the city level, if such kind of figures tell us about which are the particular areas from where we have a disturbing trend, then we can early diagnose, we can have early warning system, and we can develop the facilities, we can improve our capacity. For example, as the Dr. Bilal has said, that if a lady makes 3 cups of a tea, and on the next day you ask him to prepare 300 cups of tea, then perhaps he would not be able to maintain. So that's why if we have such an early warning system, then we can develop our capacity, we can have improve our logistical backend, we can involve community in mitigation measures. So I think this is the role, and there is the role of the civil society where they come. They tell us about this is the particular area where you need to focus upon, because as you see, the government is such a large universe that we have so many businesses to do. Within the Lucknow municipal corporations, there are more than 20 departments. Healthcare is one of them. So within the Lucknow municipal corporation, there is some kind of civil society which is coming and telling that this is the particular area where there is a possible chance of outbreak. So then we have a targeted approach for that particular area. So this is the role, and I think with growing level of development and with more prosperity, definitely the role of government will shrink toward the areas where we have said, as I told, in making making policies, decisions, regulatory role, and more things will shift to the private sector.
Thank
Thank you.
you, sir. Manish, you have been thinking very hard about how to translate some of the intelligence or the data. I know you're a strong votary that data in a PDF file is not useful. So can you just talk about your idea on how to synthesize and translate? And secondly, how do you see actors like Precision Health and your own initiative, AMR ACE, interfacing with government and contributing to successful translation?
Okay. So AM RACE, this antimicrobial race, is an initiative which we have started by partnering with the government of Karnataka at Bangalore Bioinnovation Center. The whole idea is, of course, there's a lot of activity going on surveillance and data collection. Yeah, that's very exciting to learn the problem, to find what are the challenges. But my goal has always been closing the loop, being a translational scientist. So what we are doing is working with some of the premium institutions in the country, like AIIMS. We are developing a software called as AMRX. Now this software connects what the prescriber is prescribing with what is being dispensed by the pharmacist and what happens in the poop, the sewage, the wastewater. Because wastewater is where usually I say, when bugs of various varieties come together, they have knowledge party. They share the genes. The naive bacteria will absorb the resistances from the hardy ones. So this information spread is very dangerous. So if this software can connect this data and get back to the clinician and tell, hey, listen, in your area, resistance to ampicillin or amoxiclav is increasing gradually, they can practically start reducing the use of those particular antibiotics. That way, reducing the pressure of antibiotics on the bacteria, automatically, they reverse, because no antibiotic resistance is permanent. It is transient. You remove the antibiotic, again, because microbes are highly resource, they're very conservative in using the resources. So they again start becoming susceptible. That way, we can extend the life of the antibiotics for a longer period, because as we all know, antibiotics are the pillars on which every therapeutic area stands. Our human longevity is based on antibiotics. If there are no antibiotics, again, we'll go back to 50 years lifespan. So this connecting these three people, stakeholders, is very important, because unless we close this loop, every exercise is only in silos and doesn't make any sense. That's why I say, connecting these three stakeholders is very important.
Great. As a clinician, I'll just add to this. So one of the, so antimicrobial stewardship, it's a very paradoxical activity, because in no other area do you say, look, you have this great drug, don't use it because we need it for the future. I think, one of the things precision health data has done for me is, as a doctor, I practice as an infectious disease physician or a family physician, multiple hospitals or locations. I actually am beginning to see correlations. I can't talk at a scientific, at a level where I can say this can be ascertained, but I can see signals where in the local area where your hospital is located or clinic is located, what is the antibiotic resistance pattern among key bacteria, especially gram-negative rods like Klebsiella. For example, one of the things we saw was very high levels, nearly 30 to 40% resistance among Klebsiella in the sewage to carbapenems or drugs like meropenem, ertapenem, imipenem. The challenge is, in terms of choosing antibiotics, this is kind of the last line. After this, you're going back into a previous era, 1970s, really. So we saw significant things, and I think one of the directions precision health should consider looking in, and I think groups like yours will have a huge role, is the contribution to antibiotic resistance does not only come from usage in clinical settings. The vast majority actually comes from usage in animal husbandry, in agriculture. So mapping those sites and the sites from where, for example, I was surprised to see colistin resistance. This is because colistin is used in poultry. So tracking where is the effluent, where is this being used and where is it flowing into the sewage, and then checking the levels of the antibiotics. This kind of intelligence, early warning system and early corrective system, which can be shared with the government, I think would be critical. That's a direction probably we need to think about. I'll invite Bhaskar. Dr. Bhaskar, you were in a very interesting position. You, as a public health practitioner, as a public health physician, you understood and participated very closely in the innovation process. You also participated in the sense-making process, because the administrators like the chief commissioner or the special commissioner would ask you, because you're a doctor and you're the head of the COVID war room, but you also were part of government. Can you speak about how sense-making and action, how does that happen in, the complex type of interactions we were having, which was really a learning curve. We were all going through a collective learning curve. Can you share your experience, please?
Sure, Arbi. So, to set a context, when we started interacting, I think almost 3 years back, like you rightly said, we are all in a learning curve. So, we just wanted to consume whatever was available. So, we were looking for answers. So, when COVID started, nobody knew what's happening. So, we were looking how it's happening, how it's spreading. So, when somebody came and said, okay, this is how it has been spreading, it's spreading in sewage, it's like, okay, you test for it. Like Pandeyji was saying, government is in no business of making any business. So the only question, if you remember, we asked is, are we supposed to pay anything? So you said, no, we are doing it pro bono and this has been funded. We said, okay, well, go ahead, do it. If we find anything, then it will be of use. So that's how it all started. But like you rightly mentioned, most of the information started making sense. Really making sense is when we started putting multiple puzzles together. So we were doing a lot on strategizing how do we test, because testing was the main thing, how we could identify how COVID is spreading. And the next thing was people were starting to agitate on all these lockdowns, rules, regulations. We needed a way how we can answer people. Like, this is how COVID is spreading. This is why it is happening. Why are we locking down certain areas? Why are we not locking down certain areas? Why are these time restrictions? Why are we saying that you need to maintain social distance? We needed answers for all of this, and which are convincing enough. So that's why we're looking at, okay, now we are testing. This particular area has a lot of cases. That is one thing why we are restricting you from spreading it further. Second thing, how do we restrict it from spreading inside also, is where we started looking for environmental surveillance samples and say, okay, we are seeing a rise in sewage. That means the COVID still not has got into the clinical stage here. if we can raise testing here, then we may be able to stop the spread there. So that is the answer what we could give to people. The main thing what government was looking at, or the policymakers were looking at, is one, to frame a policy, I need something which I can base upon. If not for COVID, for multiple other things, we have clinical studies, we have backup data, we have some precedents. Something is being done previously which we refer to and make a policy, but COVID we had nothing. We could look at other countries, but that's a different example as you compare to India. For even for Bangalore to look at some other districts or states, it's a different example all we need to take because the habitats are different. Considering that is when environmental surveillance really started making sense for us. We could tell people that we are seeing more number of cases in this particular ward in the sewage, which really means there may be a rise in number of cases clinically in a week's time, which made sense for us to tell people, I'm going to test in your area more. If somebody from BBMP comes up to an apartment and says, I'm going to test here, usually the apartment fellow will say, no, there are no tests in my apartment, no cases in my apartment, why are you testing? So I had something to say, I have found something in your sewage, so means there is a case which is not showing up. If I test, I may be able to find out, and if that person is isolated, the whole apartment is safe. So we could find such answers. So that is what we look for when there is some innovation and some research.
Great, thank you, Dr. Bhaskar. I think this strategy should really expand to year-round. So one of the things is year-round we have different outbreaks. Like now we are bracing ourselves for a dengue outbreak. But this kind of hyper-local knowledge, early warning system, when translated with local actors, I think holds huge potential. So in the remaining time, I want to do two things. I want to ask Dr. Varsha a few questions. And then actually I want to wrap up with the last segment, which is who should pay for the spread, scale, and sustainability of this idea. And I think there may be a very interesting debate even possible. Dr. Varsha, so your lab really started off as an innovation lab. You started off as an innovation lab, and then your lab really scaled during COVID and became one of the largest labs doing clinical COVID testing. And you were the core partner of Precision Health. How do you think for social enterprises or private labs like your own, what are the kinds of opportunities that Precision Health offered you to solve public problems, and how has this transformed you as a professional and your company or enterprise?
Thank you. I think the biggest, probably the change that happened in me and in my company by extension was an expansion in imagination. So before COVID, as RK just mentioned, we were a very small R&D lab. We were developing diagnostic tests, mostly in the space of bloodborne pathogens and viruses like HIV, HCV, HPV. When COVID happened, we were like, okay, there seems to be a need for diagnostics. We're going to pivot. We're going to go from R&D to diagnostics. Our conversations with Angela had started around that time, and testing wastewater was just another thing we did during lockdown because there was really not much we could do at that time. It was like, hey, we have time, we have all the reagents, and it was like a nice intellectual exercise to see how do we develop a protocol in lockdown with minimal supplies to get the same results that people are getting abroad. So it was like a puzzle which was kind of fun to solve. And I think that was our initial sort of foray into environmental surveillance or precision health. Over the next 3 years, working very closely with Angela, with all the other partners in the precision health group, and I have to say the biggest learnings actually came from the fights and the conflicts. Because I guess when everything is going very nicely and hunky-dory, you're like, oh, greatest buddy in the world, we love each other. And then when things don't go well, and your sort of reputation is on the line, and BBMP says, dude, you told me there was going to be an outbreak. There was no bloody outbreak. What the hell are you talking about? That also happened, by the way.
Angela, Bhaskar, all of us have memories of October 29th meeting.
No, October 2nd.
October 2nd meeting, sorry, Gandhi Jayanti meeting, yeah.
So Gandhi Jayanti, we called everybody, special commissioner, chief commissioner, there is going to be an outbreak, sir. And the guy was like, no, there isn't. We don't have any other signal. And then there was no outbreak. So these are the kinds of things where suddenly, as you know, Angela said, we fall flat on our faces. Everybody like sort of starts questioning you, and that's when actually I think a lot of the learning happens, because it strains your relationship, it strains your credibility, and then the conversations you have then and the fights you have then are either what make or break a coalition. And I'm really proud of the fact that our coalition kind of held together during even those extremely unpleasant times. And I think that, to me personally, was a good personal maturation moment. So I said in terms of expansion of imagination, right? So one, this sort of going from a lone ranger startup to part of a group, that was a big change in the way we saw ourselves. Second, moving from, you used a very fancy word, epistemic, something or the other, which I cannot understand, but I'll tell you in terms of language that I understand, which is basically mindset changes.
Thank you.
Which basically goes from when you see yourself as a researcher, as a molecular biologist, can you suddenly start seeing yourself as part of a larger system in terms of public health and in terms of a transdisciplinary actor. That's a pretty big mindset shift, right? And I think that has happened not only in myself, but in a lot of our people. And I'm very proud of the fact that of the 45 odd employees that we had, almost every single one of them went from thinking they were entering a diagnostic lab to learn some technique to thinking as a public health professional, saying I not only have to talk to this guy, but I also have to talk to that guy and that guy and that guy. What are the implications of my finding? Does this make sense in the larger scheme of things? Those kind of experiences, I think, are really formative for young professionals. Third thing, I think, is the advantage. You asked for about private organizations and startups. A lot of startups...
Social enterprises.
Social enterprises, sorry. For us, and I think it will be true for anybody who gets into this, is the expansion of markets. Because, yeah, sure, you could be a diagnostic company, you could be a public health, this thing. How do you actually make money? And we were really, I think, got into this rather enviable space of being the people who could work with diagnostic companies and say, give me your kit, give me your kit, give me your kit, give me your kit. I'm going to test all of them, and then I like your kit, and this is what we're going to use for the rest of the program. And so we were working so closely with very large diagnostic companies and saying, I want this kit to be able to detect this gene, this gene, this gene, and I want it to be quantitative, and I don't want my technicians to think too hard about the mathematics, so please give me an algorithm which they can just feed, and it spits out a result at me. And that, I think, was pretty cool, to be able to say, you make the test that I want. So that was kind of cool. And fourth was the data. To go from a lab that was producing data but not really being able to see the larger picture, but to be able to get to a position where we are seeing not only the entire city's data from the sewage angle, but the entire city's data from the clinical angle, integrating them together, talking to doctors and saying, what are you seeing in your ICU? Tell me, because I need to know to make sense of this. And people would give us information. And then we were also doing genomic sequencing, so we called up patients and said, did you take a vaccine or did you not take a vaccine? If you took a vaccine, when did you take it? Because I'm seeing this weird variant, I want to make sure that this is not some random new thing. So those were the kinds of things, I think, when I said in terms of expansion of imagination, that is a pretty big, mighty jump, right? From going from just like being in a lab to like talking to everybody in the city and say, give me your information, give me your information, give me your information. And then you make this into a beautiful chart and then you give it to BBMP and say, this is what I'm seeing. What do you think? So I think that was it.
Thank you. So we'll end with the last segment. But I want to acknowledge, I think, two types of actors. Vishwanath, I'll be asking you a question about who should pay. So two types of actors. One is the intellectual contribution of actually the public health agency. So BBMP, we think of government, I mean, actually I think we are indebted to one of the sense-making meetings which happened at BBMP, which BBMP was very kind to host. Of course, the Precision Health team led it, but where the special commissioner asked this, signal from noise cutoff question, where he said, what is it, at what level of RNA, of viral load in the sewage should you actually cry wolf? And there were significant intellectual contributions, which I think I really want to acknowledge. That when all the stakeholders, parties work together and engage in this tussle to understand, that there's a lot to be understood. I think we'll come back to this question of who should pay, because one of the challenges, and Pooja, you were talking about this, one of the challenges with innovations like this, innovative ideas like this, once you've shown that the innovation has promise, then the question becomes, how do you spread the idea, scale the idea, sustain the idea, and how do you prevent it from either non-adoption or abandonment? Now, Precision Health has shown so many fascinating and extremely valuable things. So in terms of scale up, going to the next level, I sometimes sense, and I could be totally wrong, this is the platform to discuss, that different funding, stakeholders with funds or resources where they can, for example, government, for example, large philanthropies, and potentially others, have sometimes a difference in opinion. So I'd like to ask, start with Vishwanath. Vishwanath, who should pay for scale up? And I know your own work with Kere Sanjeevani, for example. Kere Sanjeevani, for those who don't know, is the second largest urban wastewater reutilization program in the world. Bangalore receives something like 1,400 million liters a day of water from Kaveri River, and it draws about 600 million liters of water from the ground level. It produces about 2,000 million liters, and our neighboring districts are in drought. But this Kere Sanjeevani project for the last 3-4 years pumps treated wastewater, and we've seen large-scale adoption. But it looks like most of the funding came from the government. So who should be paying for scale-up?
So one of the things is that from the testing that we did, I think we have to start to identify bellwether wastewater treatment plants or bellwether stations, right? A city of 16 million can't afford each one of its wastewater treatment plants being tracked. So the system itself will have to identify and come across a matrix, artificial intelligence, or some way by which we zero in on a small population, which will then indicate what the rest of the city is doing. I think that's an intellectual challenge that we'll have to think through and work. The second logic which is there in wastewater is that polluter pays is the principle. Whoever sends waste out into a system, in theory, the principle is that that person should pay for the treatment and release into the environment. Now the question is, if that wastewater contains virus and bacteria, should that principle still follow? In my ideal world, the wastewater treatment plant itself will have a lab which will do a tracking of what it now tracks, physical and chemical parameters, but also will track biological parameters. And that tracking will be based or done by the local body or the utility which is running it in itself.
This lab, you're saying, will be owned and run by the government?
Every sewage treatment plant has to have its own lab. It tests currently about 8 parameters. That same lab should have its facility and capacity expanded to be able to do the tracking, which will be vital for the city. But I'll just also add one more point to it. One of the things that we have to internally debate, is the relevance of epidemiological surveillance itself. Are we claiming success based on what we've seen in clinical trials and been able to say, oh, we saw it 1 week back? But has that been ex post facto, or has it actually translated to an early warning which has really helped a lot? We'll have to fine tune that particular point of the argument. And the second crucial thing which we should internally debate is the ethics of data. Who owns wastewater? Who owns the data of wastewater? What will that information? I know that SCOL, for example, or others who have been funding, talk about an open, transparent platform. An open, transparent platform in itself will not be politically benign. It's not in a structural inequity existing in society. Open, transparent platforms in themselves are absolutely of no use. They actually exacerbate inequity. And we have found during the pandemic, targeting of specific groups, be they religious groups, be they class group, economic class group, not in the nice sense, but in the bad sense also, because that's the way data is used and data is politics, right? So I think somewhere that internal debate also has to come from within the surveillance community as to how do we make it genuinely equitous, how do we address structural inequity and the way power acts in itself. That has to happen. So that's linked to who does the testing, right? So who does the testing? Can it be a private player who's doing the testing? What is the value of the data? Who owns that data? And what responsibility and accountability is for that data? Because that data is a gold mine, right? In the AMR now, for example, it's going to be a gold mine. But gold mine for whom? So I think these are the tougher questions which hopefully when Angela arranges the next get-together, we'll have a panel discussion on that too, right? Thanks, RK.
I think you've given us the topic for the next debate. What would you say, sir? In terms of who should pay, sir, who should pay for the scale-up and adoption, sustainability of these programs?
In my opinion, as I've told earlier, the private sector and R&D organizations should pay for it. In return, they get the intellectual property rights for the utilization of such equipments and concepts. Over a period of time, they get IPR for it. And government may subsidize for those peoples who cannot afford it. So in my opinion, the private sector and R&D organizations should pay for it.
So there's some diametrically opposite views here. And
Depending upon socialism and capitalism.
well, public health is politics. Bhaskar, what would you say? I mean, you did allude to the one single question BBMP asked, do we have to pay?
Yeah.
And by the way, you know, one more thing which I learned through all this is the difference between profit and money. A profitable company is not necessarily something which has money to run its cash flows, you know? And these are challenges which come up in public-private partnerships, working with government and things like that. So
to make it simple, I think these are the areas which stand out as clear examples for public-private partnerships. So we have seen many things which happen as a PPP model, as simple as things like setting up a public toilet, putting up ad boards. These are running on PPP models. I think research is something which should run as a PPP model. In my clear opinion, government should fund the initial tranche. So if there is a buy-in from the government saying this is something of use for the larger society, there'll be a lot of people from the private sector also who will pitch in. The initial buy-in, however small it is, at least the acceptance from the government should happen as the first one. As a follow-up, PPP should be the model to go ahead. It can't happen if you depend only on one player. It cannot happen if only private has to fund. It cannot happen only if the institution has to fund. It cannot happen only if the government has to fund. It has to be a proper PPP model to run a successful and sustainable research.
Okay. I think, thank you very much. But I think there is a difficult question here, because when your intervention is going to help those who are the most vulnerable and the least likely to be able to pay, then how do you build a market model? And I'm not propagating a political view here, but I'm raising this as I think something for genuine debate discussion. Pooja and Ramnath, what are your views on who should pay and what should be the role of even your own organizations?
I can come from my experience. So how solutions get picked up by the government. So usually what happens is when you go to a government saying that I have this solution, it takes a lot of time because government doesn't want to take risks, because government inherently cannot take risks because of their administrative this thing, and also accountability to the people. So they don't usually take risks. And it was also designed like that. So same way with the doctors, they don't take risk unless there is a back end who is doing the research and coming up with this. Unless it's proved that it is not going to be scaled up. And it's a good way, because if there is something wrong with the government, it scales up that much multiple times. So it's, I think what, at least from the crypto relief point of view, is there should be organization who could de-risk this thing for the government. So they can, people who can think alike could start helping. Like Precision Health is like, like Skoll took that initiative to take that risk, that it's not about the number of people or number of this thing. Let's try it the new way. And how can we make it available to large funders like World Bank or anyone, the government itself, to scale it up once proved. So what we think that partnering with the government is the first, definitely a big step, so that they already are in the solution making itself. Instead of we trying to sell the solution later, it takes another 15 years to kind of bring that by the time the problem is solved or it gets escalated. So working with the government in the initial step itself gives a lot of insight what government thinks and also the solution coming out. So it is much more easier for them to internally get the buy-in. So that is one thing. And there are a lot of other platforms within the government to like the PPPs, ROPs, they have their own innovation funds which could be tapped and also be supported. So I think at various levels, I think people can take part, like the CSR to scale it up in the local areas, or the big multilateral agencies, the World Bank can really work with the center, the state, big funding to scale up the solution which is already tested, proved. So I think organizations like us would really come up, help in finding the solutions, ground up, what is working, what is not working, how can we build that innovation capital at the ground. I think that's where we are thinking and want to place ourselves, yeah. So
Thank you. Shama.
I just wanted to say that we have seen, right, polio surveillance is done by the government, right? It's been done for decades. It's not new. We've seen that when we had HIV testing, scaling, viral load, etc. start, it needed, because it was new technology, you yourself mentioned TrueNat, which is now in India. So we have a curve, clearly where there is understanding, intellectual property, technology, partnerships, bringing down and understanding what the unit costs are and how it scales, etc. So I think, like Dr. Bhaskar was saying, there is a need for government to recognize that there is partnership and an area where many people need to come in and partner and work. And once that playing field is created, or that space is created, and where there is partnership, like Dr. Ram was saying, I think there is going to need to be funders, etc., who come and de-risk, because there is an initial amount of investment to figure out the tinkering, the understanding. You don't know everything, right? But once we have it running like clockwork, we've seen the government scale. I don't see that that is necessarily a challenge. I think if we were to look at over time for many, many, many conditions, once it's figured out and you know clearly what needs to be done, the SOPs are in place, the unit costs are in place, lab ka kya requirement hai, kisi aur part. I mean, once that gets really standardized, it does become part of the government machinery. It is possible to do it. But I think we do need to give it that time, make those initial investments, and then all partners work so that it can come into the system holistically.
Great. No, that's very useful. Thank you, Shama. So we're running out of time. Last question to you, Ben. Your comments on who should pay for Scale Up. And the second part is, in whatever funding is given, there has to be space and room for adequate learning. Like, for example, as a clinician, when a patient has a fever, for example, like I gave the example of the second influenza utilization curve, where only 12% was actually influenza. The rest was not COVID either. It was some other virus. So many times, as clinicians and public health, problem solvers, we think of multiple possibilities. But sometimes the funding mandates are such that there is funding for typically linear. I'm not saying necessarily this funding was like that, but it's for linear things. You can test COVID, but you can't test for, say, metapneumovirus, right? So question for you is, number one, who should pay? Just add to this discourse. And secondly, what are some adaptations that philanthropic funders who fund innovation and learning can do to promote this kind of real-world learning, which may be unpredictable?
Thank you. No, I agree with a lot that has been said. I think what Ram shared in terms of we think a lot about graduating capital from very very much risk-oriented capital to very risk-averse capital. And government, of course, has to be very risk-averse with their capital. And I think we often see that scale going from philanthropy and philanthropy like Skoll, which tends to give general operating support, which tends to give space in our grant terms for experimentation, like you mentioned, to more institutional funders, to sometimes buy multilateral funding, to government funding. And I think I agree on that pathway. I also, my personal perspective is that everyone needs to move a bit down the chain and embrace a bit more risk, embrace a bit more flexibility. And I think related to that is, we all have an inherent challenge as investors, I think in social innovation and solving social issues of short-termism. We don't have that same issue when we're investing in tech unicorns, but we have that issue when it comes to investing in social issues. And I think we don't live single issue lives. My being sick would not be independent of my economic livelihood, of my standing in society, of the impact on climate change on my community. And I think if we can start to think a bit more intersectionally about the issues that we're trying to solve, I also think that would be helpful in terms of investing now for a payoff and for the knowledge of what we're preserving in the future. That's very difficult. I'm sure our colleague from government can share. I mean, we obviously operate on short cycles for many of our stakeholders, including citizens. But I think that if we can move a bit more towards flexibility, a bit more towards innovation, and we can start to think more intersectionally about some of these solutions, I think we end up in a better place. One example of that, and then I'll end, is that we have a partner called Map Biomas in Brazil that does deforestation and land use mapping so that they can try to curb the ongoing deforestation in Brazil and have the right data to do so for the government to take action. And as we all know, deforestation is also linked to pandemics. And they actually, unbeknownst to the organization that's primarily focused on environmental issues, a public health group started using their data and their real-time tracking of deforestation to track the migration of the monkeys that carry yellow fever in Brazil. And then they used that information to do ring vaccination based on that deforestation data. So I think we often overlook, including people that are in the work, we often overlook the amount of interconnection and the amount of long-term impact that figuring out, like you said, sir, figuring out some of these thorny issues can have a really long tail of impact for our communities and our societies. So I would encourage us all to shift a bit more innovatively and to shift a bit more into flexible, intersectional investment in these spaces.
Thank you very much. So we'll end the panel discussion with that. But I must congratulate the Precision Health team for bringing together such a rich network of people and for enabling such a robust and rich discussion. Thank you very much.